Welcome. Thank you for joining us today in the presentation of our healthcare policy analysis, Overcoming Financial Impacts of the Two-Midnight Rule. This report was prepared by Florida International University Healthcare MBA Management Team 3 for review by the West Kendall Baptist Hospital Executive Team. The report was completed in partial fulfillment of MAN 6974, Master's Project in Management, and under the guidance of Professor Miriam Wiseman, course instructor, and with the support from Sarah Hamill, our writing coach during the spring 2020 term. Before we get started, we'd like to briefly introduce our management team members. My name is Sam Achenbach, and I'm physically located in Philadelphia, Pennsylvania. I studied at Widener University and gained my bachelor's of business administration prior to graduate school at FIU.
Thanks, Sam. My name is Belinda Bullinger. I'm physically located in Miami, Florida. I studied physical education at Florida International for undergrad prior to enrolling in the Healthcare MBA program with FIU.
Thanks, Belinda. My name is Lauren Brown, and I studied biology at the University of Alabama prior to enrolling here at FIU.
Hi, everybody. My name is Janina Fischer, and I'm located in Germany. I studied Bachelor in Nursing at Carol Davila Nursing School in Romania, Bachelor in Economics at Academy of Economic Studies in Bucharest, Romania, and also I'm certified professional coder through APC.
Thanks, Janina. My name is Sofia Lacayo, and I'm physically located in Miami, Florida. I studied recreational therapy at Florida International University prior to graduate school at FIU.
Lowering observation care costs while upholding care quality standards and excellent patient experience is a challenge for the West Kendall Baptist Hospital executive team. Analyzing factors that contribute to observation care costs under the Two-Midnight Rule, such as reimbursement, length of stay, and regulatory obstacles, could help the hospital to avoid unnecessary observation care costs. Further, improving quality ratings, optimizing emergency department throughput, or eliminating observation status altogether could help West Kendall Baptist Hospital overcome financial impacts of the Two-Midnight Rule. This analysis will distinguish Medicare Part A and Medicare Part B reimbursement opportunities. It will consider Medicare payment penalties, employee turnover, emergency department wait times, and hallway boarding as areas for improvement opportunities using benchmarking techniques. It will determine a recommendation about strategy for overcoming financial impacts of the Two-Midnight Rule.
The Two-Midnight Rule, introduced by CMS in 2013, was implemented to clarify a hospital inpatient admission and corresponding services under Medicare Part A. Short hospital stays expected to span less than 2 midnights do not meet criteria for those perceived higher reimbursement rates of Medicare Part A and are instead reimbursed through Medicare Part B rules, creating cost challenges for West Kendall Baptist Hospital and providing quality care to its observation patient population. In 2015, CMS announced updates to the rule based on extensive input from hospitals, physician practices, and other stakeholders. Under these updates, the two-midnight benchmark remained unchanged. However, hospitals and physicians can now receive Medicare Part A payments for short hospital stays as determined by the admitting physician on a case-by-case basis with appropriate documentation to support medical necessity. Further, payment determination could be based on the appropriateness of the physician's patient status decision and the outcome of a short stay medical review by a quality improvement organization. The Social Security Act of 1965 established Medicare as a health insurance program for the elderly. Medicare is a health insurance plan with 4 parts: A, B, C, and D. This healthcare policy analysis will focus on Medicare Part A and B. Medicare Part A covers inpatient hospital admissions, skilled nursing facility admissions and care, and a select few of home health care services provided to individuals who are 65 years old and older or under the age of 65 with certain disabilities. Medicare Part B reimburses physician services for outpatient visits, preventative services, lab tests, outpatient hospital services, home health care services, cost of durable medical equipment, and other medical services not covered by Medicare Part A. It is a common perception that Medicare Part A pays more due to the cost of providing care during an inpatient hospitalization visit. It is also a common perception that Medicare Part A pays more due to the cost of providing care during an inpatient hospital visit compared to Part B, who only covers outpatient services.
So the Hospital Outpatient Quality Reporting Program, mandated by the Tax Relief and Healthcare Act of 2006, was implemented by CMS to link Medicare payments of outpatient hospital services to quality data reporting. Hospitals that fail to meet the hospital OQR program standards receive a 2% payment penalty from Medicare applicable to OPPS payments and co-payments. The measure set includes long-standing quality measure OP18, a measurement of the median time from ED arrival to ED departure for discharged ED patients. First implemented in 2012, this measure aligns with measures of the National Quality Forum. It requires quarterly chart abstraction, patient-level data reports, and it is also publicly available to beneficiaries through CMS's Hospital Compare website. Perhaps more costly than the OPPS payment penalty for failure to report quality measures is the cost of receiving a poor quality rating or score. A quick look at West Kendall's OP18B quality rating for calendar year 2018 compared to the national average here shows that there is room for improvement in ED throughput and wait times. Many studies have looked at the impact of ED crowding and length of stay on the patient experience. One analysis found that each extra hour of ED length of stay could be associated with a 0.7 decrease in top satisfaction rating, as well as a 44% increase in the odds of ED departure without being seen. Another analysis found impacts of ED crowding on patient mortality that suggests even a 10% decrease to ED patient volume could significantly reduce an average patient's chance of mortality. As regulatory changes push the healthcare reimbursement system toward pay-for-quality arrangements like those of the hospital OQR program, quality ratings in general become more and more important to hospitals for reimbursement. Some contributing factors to length of stay include hospitalists. They provide most of all observation care and are in turn West Kendall Baptist Hospital's greatest asset in lowering observation care costs. Today, hospitalists face a very costly and billing coding dilemma every time a new patient arrives, inpatient versus outpatient. Each patient status decision has a direct impact on the cost of care for the hospital and for the patient. For hospitalists, the 2-midnight rule is a burden and a source of frustration that could contribute to employee turnover. West Kendall Baptist Health information on employee turnover was provided in the case study in the strategic plan, and it is summarized here on the left. Another factor is observation units, the units that are dedicated to providing protocol-based care to patients with well-defined symptoms or diagnosis. These are prevalent in the US, and they are an integral part of the WKBH care system in addressing length of stay. These units have helped to manage challenges of observation care. WKBH implemented theirs in 2012, and the information on direct costs and total costs of observation care was also provided in our case study in the patient dashboard for fiscal year 2016, and it's summarized here on the right. West Kendall Baptist Hospital's average length of stay for all observation patients is 35 hours based on this dashboard. And the estimate places WKBH in the lowest performance percentile according to recent data from the advisory board company as shown here in the middle. Again, another opportunity for improvement.
Lowering costs for providing care to observation patients while continuing to provide quality care and an excellent patient experience involves several major stakeholders groups, including CMS, West Kendall Baptist Health, hospitalists, and patients. CMS is a federal agency that is working to continuously improve the way healthcare is delivered in the United States. Based on this reality, this organization was created and is maintained by the federal government, is heavily influenced by many political factors. These political factors will influence many variables that ultimately impact the reimbursement rate for healthcare providers such as West Kendall Baptist Health that they receive for services they perform on patients that are part of these programs. As it relates to observation care, CMS sets the rules relating to reimbursement and in turn will influence how care is provided to patients. This rationale applies to the environmental factors as well as CMS will identify key metrics and utilize the reimbursement rates to influence how care is provided. In the past, the healthcare industry has witnessed CMS update regulations and adjust rules based on desired outcomes. Furthermore, CMS collects large amounts of data to which it is able to analyze and create valuable insights from. As such, it is highly practical that CMS will have the resources directly influence West Kendall Baptist Health's quality patient care and revenues. Hospitals such as West Kendall Baptist Health are on the forefront of care in the U.S. healthcare industry. These organizations are heavily impacted by political factors put in place by the government interventions. As such, these organizations must comply with all rules and regulations created by many political factors acting upon their organizations. These organizations have some but limited influence over these political factors affecting them. Furthermore, these organizations have some but limited control over existing environmental factors. As an example of an environmental factor that a hospital has control over is the population they serve. Lastly, it is practical for these hospital organizations to ensure high quality care is received, also ensuring that a maximum reimbursement is paid for services rendered. As it relates to quality care for patients, while continuing to reduce costs, hospitals dictate the care that is received by these patients. This care is influenced by all factors above, including political, environmental, and practical. Hospitalists, physicians, nurses, and all other direct care staff employed by a hospital are an integral part that will allow West Kendall Baptist Health to ensure that quality care is provided and while ensuring profitability for the organization. These individuals have little control over political factors as individuals, but as a whole can work as a collective to influence these factors. Environmental factors are preset for this group, and there is little effect that this group can have as it relates to these factors. Furthermore, these individuals work directly with the patients in need. As such, they determine the care that is provided to these patients and actively affect reimbursement for the organization, as well as the quality of care. This group has the greatest practical impact on these factors for the hospital organization. Lastly, patients are the reason that this entire system exists, in order to address their needs as individuals and improve their overall quality of life. Ultimately, this group's influence over political factors is like that of the hospitalist, wherein, as a group, they will have the greatest impact on these factors. The difference resides in that the typical political factors these individuals can influence, which will be far broader than that of the hospitalist. Additionally, these individuals have little influence over environmental factors, but are heavily impacted by these existing factors. As such, the environmental factors that they live within will determine the quality of life they have. Finally, these individuals have the final say in the treatment they receive from the hospitalist and drive metrics tied to the quality of care received. As such, they hold a significant amount of control over these practical factors, and their needs must be addressed.
Executive team should consider 3 proposed options to lower cost of providing care to observation patients. So the hospital can continue to measure and improve outcomes that connect to quality ratings and coincide with the triple aim. The hospital can improve ED throughout by reducing door to discharge time and discouraging unnecessary ED visits. And the hospital can petition to eliminate hospital observation status with the use of a DRG modifier. The West Kendall Baptist Hospital executive team should consider 3 proposed options to lower costs of providing care to observation patients. The first option is to improve the patient experience and reduce observation care costs by continuing to measure and improve outcomes that connect to quality ratings and coincide with the triple aim. So West Kendall Baptist Health can focus on measuring the outcomes that connect to the OQR quality ratings to avoid loss of revenue through the 2% penalty, as well as the hospital can adopt new measures of the OQR system to evaluate outcomes connected to quality ratings and reduce costs while improving the quality of care. These recent measures include the OP35 and OP36. OP35 covers outpatient chemotherapy patients that visit the ED or observation units. CMS recently introduced changes to OP35, which are scheduled to take effect for the evaluation of performance for the year 2020. In its current form, the OP35 quality measure excludes several types of patients from this category, including patients with scheduled hospital visits and patients receiving therapy for autoimmune illness. These excluded patients will be charged under a different reimbursement determination. So according to Saul and Kadri, these were small but significant improvements in ED utilization and inpatient admission rates under OP 35. Specifically, there was a 0.3% decrease in inpatient admissions and 0.2% decrease in the ED rate. This suggests that adopting the new measures can reduce costs at West Kendall Baptist Health Observation Unit. The second option is to improve ED throughput by reducing door-to-discharge time and discouraging unnecessary ED visits. The hospital can reduce costs and increase the efficiency of its observation unit by reducing the door-to-discharge time. Reducing this time and improving the timing of discharge can reduce overcrowding and increase the unit's throughput. The hospital can achieve this using the Lean Six Sigma approach to quality improvement. In a hospital-based study focused on eliminating barriers to the discharge process in an inpatient setting, these interventions resulted in increases in discharge rates at 10 a.m., which is like 21.3 points, and noon, which is like 7.5 points, without affecting a 30-day readmission rate. These improvements can increase the throughput and reduce overcrowding in the ED, thereby enhancing quality, reducing costs, and improving efficiency. The hospital can enhance service delivery and reduce costs by reducing unnecessary visits to the ED and observation unit. Reducing unnecessary visits to these service centers can improve efficiency by avoiding overcrowding, since only patients who need the services will actually be there. A potential solution to this problem is promoting the use of the Care on Demand telehealth solution. This solution allows patients to communicate to the physician and get treated remotely via the mobile phone. This would reduce the necessity for patients to visit the ED and the observation units if their conditions do not warrant a physical visit. Reducing these visits will reduce ED and observation unit resource utilization, thereby reducing costs. At the same time, reduced overcrowding improves the quality of care. The last option is to petition to eliminate hospital observation status with the use of a DRG modifier. The problem that West Kendall faces is that it can be solved by abandoning the observation paradigm entirely and replacing it with a new system based on disease-related groups. Society of Hospital Medicine concedes that observation units provide the best care service for some patients. However, the observation unit system has its disadvantages as a Medicare regulation. This is evidenced by the West Kendall case, where the costs for operating the unit have been on the rise, resulting in losses. If Medicare abandoned the two-midnight ruling, the hospital could instead use a DRG modifier to account for the cost. This would be implemented by creating a modifier for all hospitalized patients that do not require the full scope of the relevant DRG. Under this system, all patients that need admission would be charged a fee for the full DRG or a low acuity modified DRG. In all cases requiring admission, the patient's condition would be reviewed to determine whether he or she needs the full spectrum of services under the DRG or not, thereby enabling the hospital to determine whether to apply the DRG modifier to a case. This allows the observation unit to revert to its traditional usage as an ED extension, where patients spend most than 24 hours. Any patient who needs to stay at the hospital longer than 24 hours but does not require full inpatient services would be charged a predetermined portion of the full inpatient fee for a given DRG. This option could reduce clinical resources usage, thereby reducing costs.
Thank you, Sophia. We've evaluated each of these options using the following criteria: feasibility, cost, and sustainability. These options were assessed using low, medium, and high ratings. The outcome is summarized here in this table. Based on our analysis, we believe that WKBH, the executive team, should focus on implementing a combination of options A and B to lower costs in providing care to observation patients while upholding care quality standards and excellent patient experience. These options rank higher in operational feasibility, cost, and sustainability. Some challenges with option A will be staying informed about quality rating systems and on top of public reporting agencies, because these influence patient and consumer perspectives on the hospital services as well as reimbursement rates. And some challenges with option B will be addressing the challenges of hallway boarding, since this is a norm at West Kendall, and addressing the rising patient populations.
Our purpose was to determine appropriate alternatives for West Kendall Baptist Hospital to lower their cost directly related to the care of observation patients. Although lowering cost is the main area of concern, it needs to be done without lowering the expectation for quality care and an excellent patient experience. The Two-Midnight Rule is causing the hospital to miss out on potential reimbursement opportunities between $500 and $1,200 per patient. Because of this missed financial reimbursement, West Kendall Baptist Hospital needed to find additional ways to improve their intake or funds reimbursed by the government or other ways to compensate for these potential losses. Through avoiding payment penalties of the OQR program and other pay-for-quality programs, West Kendall Baptist Hospital could avoid unnecessary financial loss while improving patient satisfaction. It is our recommendation that the hospital should focus primarily on instituting option A, improving quality ratings, and option B, improving emergency department throughput, as option C is beyond the hospital's full control. Although the cost of keeping up with pay-for-quality programs is significant, overall sustaining high-quality ratings will be the most beneficial in maintaining high-quality patient care and satisfaction.
So this concludes our presentation, Overcoming Financial Impacts of the Two-Midnight Rule. Thank you for joining us and best of luck.